Rigid or flexible cystoscopy with botulinum toxin injection, a technical guide. Cystoscopy with bladder botulinum toxin injection is a procedure for adults with idiopathic overactive bladder or neurogenic lower urinary tract dysfunction, such as those with spinal cord injury, refractory to medical therapy including anticholinergics. This therapy has been FDA approved for these two indications since 2013 and 2011 respectively. The overall management of neurogenic bladder and overactive bladder are described in the AUA core curriculum. Acute symptomatic UTI, pregnancy, and lactation are absolute contraindications to cystoscopy with botulinum toxin injection. Relative contraindications include urinary retention for patients who do not already catheterize, since this is a known risk of the procedure. Caution should be exercised in patients with primarily nocturnal symptoms. In addition, patients are usually instructed to hold anticoagulation prior to injection. A peri-procedural dose of antibiotic prophylaxis may be considered. Key adverse effects are hematuria, UTI, and urinary retention. Per the AUA SUFU guidelines, the starting dose for non-neurogenic or idiopathic overactive bladder is 100 units, with the option to escalate to 200 if symptom relief is inadequate. For neurogenic lower urinary tract dysfunction, the starting dose is 200 units. In patients with neurogenic detrusor overactivity due to spinal cord injury or multiple sclerosis, prior studies have not demonstrated a difference in response between 200 and 300 units of botulinum toxin. The FDA recommended maximum dose of botulinum toxin in any single patient is 400 units in a 3-month period. For patients receiving botulinum toxin therapy for multiple indications, such as spinal cord injury patients with skeletal muscle rigidity and neurogenic detrusor overactivity, the clinician can use their best judgment in off-label dosing. Prior to the procedure, the patient's urethra and genital area are sterilely prepped and the bladder is drained. In the office setting, lidocaine gel is applied to the urethra and lidocaine solution is instilled into the bladder via catheter. This author uses approximately 50 milliliters of 2% lidocaine solution with a dwell time of 10 to 15 minutes, and also routinely uses cephalexin 500 milligrams for prophylaxis. The formulation of botulinum toxin approved for intradetrusor injection in the United States is onabotulinum toxin A. Prior to use, vials should be refrigerated. A 100-unit vial of botulinum toxin is reconstituted with 10 milliliters of 0.9% sterile, preservative-free injectable saline. Sterile water is contraindicated. It may lyse the toxin, rendering it ineffective. Intradetrusor botulinum toxin injections are most often performed in the office setting with topical anesthetic. The procedure can also be performed in a surgery center or operating room under sedation. The latter might especially be considered for higher risk patients, including spinal cord injury patients with known autonomic dyssynergia. Rigid or flexible cystoscopy may be used to deliver the botulinum toxin to the bladder. Rigid cystoscopy is easily performed in women via urethral access. This is a Wolf injection cystoscope, which features an injection needle that securely attaches to the working element. This allows excellent control by a single operator performing the procedure. Flexible cystoscopy is generally preferred for botulinum toxin injection in men in the office setting and in patients requiring bladder access via a suprapubic tract. A longer, flexible needle is required, such as the Labori Ingitac pictured here. When using a rigid cystoscope, the syringe containing reconstituted toxin is attached to the needle, which is fed through the cystoscope and secured to the working element by a screw. The urologist may deploy or retract the needle tip via the working element trigger. The urologist simultaneously controls the position of the scope and the piston of the syringe with either hand. Flexible cystoscopy uses a similar setup, with the syringe being attached to the flexible needle and fed through the cystoscope. Unlike the rigid cystoscope, the flexible cystoscope injection procedure is most easily performed with an assistant to control the syringe while the urologist handles the cystoscope. The needle tip is exposed by a twisting mechanism after being advanced into the bladder. The standard protocol, as originally described in the phase 1, 2, and 3 clinical trials, is to administer 20 injections in 0.5 milliliter aliquots into the bladder wall at a depth of approximately 2 millimeters, evenly distributed and spaced 1 centimeter apart. In practice, technique varies. Urologists may administer between 10 and 40 injections per procedure, depending on the indication and the severity of symptoms, and clinical judgment. The goal of giving multiple injections is to best distribute the toxin through the bladder and maximize effect on cholinergic motor and sensory nerve endings. The toxin acts locally on the motor end plates and nerve synapses with limited diffusion. Urologists also vary in depth of preferred injection from suburothelial to intradetrusor. Original recommendations were to avoid treating the trigone due to the theoretical risk of vesicoureteral reflux, but later studies have not substantiated this concern. Due to the dense sensory innervation of the trigone, many urologists will inject this area for theoretical benefit of urgency and frequency symptoms. Saline is generally used for cystoscopic irrigation. This is a demonstration of botulinum toxin injection using flexible cystoscopy in a male patient. The scope is inserted into the urethra and guided into the bladder. Upon entering, the bladder is briefly surveyed and the trigone is identified to orient the planned injection grid. This particular patient has significant trabeculations and cystitis cystica on his trigone. The needle tip is exposed and botulinum toxin injections begin. Injection to a satisfactory depth in the detrusor will produce a subtle ground swell movement visible in the bladder lumen. A thin-walled bleb suggests the needle depth is too superficial to reach the detrusor. Minimal bleeding from injection sites is expected. Patients should be counseled that the botulinum toxin will take full effect after 2 to 3 weeks and will wear off after 4 to 10 months. Regular, repeat injections will be necessary to maintain symptomatic relief. As there is a risk of developing urinary retention, first-time patients should follow up after 2 to 3 weeks to assess treatment response and measure PVR. Any patient with unsatisfactory symptom relief or worsened symptoms after injection should be assessed for UTI with urinalysis and culture, as well as checked for urinary retention with post-void residual.